Good afternoon, everyone. My study is on the topic outcomes of lacrimal gland injection of botulinum toxin A in functional versus non-functional epiphora under the guidance of my co-author, Dr. Hariram Ojha sir. There is no financial interest in the subject matter. As we all know, epiphora is known to be excessive tearing caused either by excessive tear production or due to poor drainage of tear. So epiphora is mainly categorized into two types, functional and obstructive. Functional, it is tearing when lacrimal drainage system is patent, but obstructive when there is obstruction at any level in the lacrimal drainage pathway. The aim of my study is to assess outcomes of lacrimal gland injections of botulinum toxin A for epiphora secondary to lacrimal drainage disorders and functional epiphora. It is a retrospective interventional study conducted over a period of 6 months. Informed consent was taken from all the patients and irrigation was performed in all the subjects to rule out any obstructive pathology. Schirmer test with anesthesia was performed to rule out reflex tearing. We have categorized the patients into two categories: patients with patent irrigation and less than grade 1 fluorescence dye disappearance test and any ocular surface disease, if present, were categorized as functional epiphora, and the other with punctal stenosis, canaliculair obstruction and NLD obstruction were categorized as non-functional epiphora. There were total 21 patients, out of which 7 patients were grouped under functional epiphora and 14 patients were grouped under non-functional epiphora. In this chart, we can see the various subcategories of functional and non-functional epiphora group. Each patient received a drop of topical proparacaine 0.5% before injection. Here is a video performing as the procedure, in which you can see that we have everted the upper eyelid of the patient to expose the palpebral part of the lacrimal gland. We have injected Botox containing botulinum toxin A transconjunctivally. It is 2.5 units per 0.1 cc. Now, after giving the injection, we are trying to deposit back the lacrimal gland into the lacrimal fossa. Patients with less than 1 month follow-up were excluded from the final analysis. And these are the results. So in this, we can see that the median preoperative Monk score was grade 4 in both the groups. But after giving the injection, it reduced from 4 to 1 in functional epiphora group and from 4 to 2 in non-functional epiphora group. And the percent improvement in outcome was 50 to 80% in functional epiphora group, and in the non-functional epiphora group, it reduced from 20 to 65% only. This is average Monk score throughout our study period. Pre-injection, we have seen that it was grade 4 in both the groups, and after giving injection at 2 weeks of interval, we have seen that it reduced from 4.2 to grade 2 in the functional epiphora group, whereas it reduced from grade 4 to grade 3 in non-functional epiphora group. At the end of the 6 months, it was grade 2 in functional epiphora group and it was grade 3 to 4 in non-functional. So there is improvement in Monk score, which shows a better trend towards the functional epiphora as compared to non-functional epiphora group. Yeah, the complications were reported in both the groups. There was one case of ptosis in both the groups, which was transient and completely resolved over a period of 4 to 4.5 weeks. There was need of re-injection in both the groups. 6 out of 7 patients needed a second dose in functional epiphora, whereas 8 patients needed a second dose in the functional epiphora after 5 months only, whereas in the functional epiphora after 6 months. And in the non-functional epiphora, 5 patients showed no reduction in epiphora also. There was no complaint regarding dry eye or diplopia. Functional epiphora has been defined very vaguely in literature, which even includes cases of partial NLD obstruction and also patent irrigation in presence of lacrimal pump failure. These should be categorized as functional nasolacrimal duct obstruction. So in our study, cases with patent irrigation and no delay in fluorescence dye disappearance tests were included in functional group, thus ruling out outflow pathway etiologies. Mechanism of action of botulinum toxin is the light chain of Botox cleaves the SNAP25 protein, which is needed for the acetylcholine to release from the vesicle. So its action is at the level of neurotransmitter. In cases with outflow obstruction, reduction in tear production is unlikely to resolve epiphora, as a primary etiology has not been addressed. However, in cases of aberrant reinnervation, which leads to increased tear production, botulinum toxin decreases the tear production and can help in resolution of symptoms. So the conclusion of my study is that the reduction in epiphora after lacrimal gland injection of botulinum toxin A is seen in both the cases, but the symptomatic improvement was more in the functional epiphora group. The clinical implication of my study is that the botulinum toxin injection in lacrimal gland is a minimally invasive, good alternative for patients with refractive epiphora. It can be performed in an outpatient setting, is technically easy to administer with a favorable side effect profile and a good efficacy viable alternative for patients who are unable to undergo surgery or who have failed symptom control with existing medical and surgical management. Thank you.
Fine. What is the biggest disadvantage with this therapy?
Biggest disadvantage with
this treatment protocol?
So, there can be transient ptosis or diplopia, and there can be dry eye.
No,
Injection.
those are the rare complication.
Yes, sir.
But if you want
So
to
biggest
treat,
disadvantage is that with the time, we have seen in our study, after the duration of 6 months, the effect of the injection reduces gradually.
that's common. That is a common. In any case of a botulinum toxin, if you treat as per the company norms, you have to just work 2.5. But in our clinical practice, generally up to 3 months.
Yes, sir.
After 3 months, you have to repeat. There is no other way. Why I am asking the question, what is the biggest drawback of this treatment protocol? As it is a competitive
So,
paper,
yes,
that's why I'm asking.
So Botox is not that cheap, and it costs. Well,
Yes. If we compare
everyone
with the
cannot afford.
other,
Yes, sir.
generally in other hemifacial spasm or blepharospasm need 50 unit.
Yes, sir.
If you want to treat in a small setup, it is the biggest disadvantage
Yes,
because 2.5 is required and the minimum vial is 50 unit.
Yes, sir. 50.
That's the point.
Yes,
Yeah.
sir.
Okay, fine.
Thank you, sir.